Very good evening for today to all of my beloved colleagues, those who are preparing for the OSCE. With my humble introduction and from our institute, good wishes with the moral alert, and going to topic of today is actually management of patients in the OSCE station. And hopefully you will enjoy the session today, and you will be surprised rather to say to know that the mistakes I am doing means mistake done by you day-to-day practice as well as in the exam. So be careful and be connected. Don't be what I say, the disconnected and distracted from the session. Okay. Anyway, so management in the OSCE station, we are not discussing the details of management in our clinical practice or hospital or other wherever. But as a family physician, to pass the exam, we must know the tips and tricks. Anyway, we discussed other skills as before with you. So far, we remember many of you attended. For example, consultation skill, examination skill, then counseling skill. And very recently, many of you attended the investigation, planning and interpretation. That was also another name as shortly investigation skill just few days back. So today, the last part of the skill is management skill, though management actually means what to us, management of disease or management of patient. Just to interact, please be connected and be talking with me. What do you understand about this? Management of disease is important or management of whole patient is important? Dr. Habib, what do you think?
Sir,
Anyone?
I think management of patient.
Yes, very right. This is the concept in the OSCE and in our real life, in our family practice. Those who understand the management of disease is the thing, what we learned in our previous life, you will be in trouble. And really, it is not a holistic approach. Always we are telling holistic approach means management of whole patient. Okay, and we diagnose the case minimum in 3 dimension: biologic, psychologic, and social diagnosis. For this reason, management of patient is the concept. For example, when we write a paper, traditionally we see in the journals, the headline is case study. I think all of you understand case study. But in family medicine, we have to say patient study, not case. As case means only a disease, only a diagnosis. For this reason, remember the word patient. We will be dealing a patient. For this reason, in the OSCE, many often you have seen it. These are the 1, 2, 3, 4, 5, and the last one is overall assessment by the examiner. But we are focusing today the skill number 4. From there, we already discussed detail about the investigations plan. And now the remaining part is the management, core part of the management. And candidate is to focus or to be oriented in these words. What examiner wants to know from your performance is, we have to consider the patient's perspective when we are planning a management and sharing with the patient, when offering investigation as well as in the treatment. We have to explain the disease management, investigation, everything in a lay people language. Another word, layman term. Then we have to convey the message or information, the risks of taking the treatment or risk of not taking the treatment. Similarly, risk of going for investigation as well as risk of not going for investigation. Risk of not going means without diagnosis, without proper evaluation, we have to treat, we have to plan for the treatment. So it will not be a confident treatment. So these are the main focused or keywords in our sense. Actually, this is the mark sheet collected from Royal College examiner sheet. but we highlight it, we focus. They didn't focus like that. This is for your benefit. We focus in this way. Many often you have seen it. Okay. So now actually we like to hear from you. Some of you, I know that practicing cases each other and how you are doing. For example, if I give you one case example, anyway, it is again highlighting words already we discussed. This is our main point, the skill number 4. And a case example like this, 50 years old, Mr. John presented with polyuria, polydipsia, and weight gain. So you diagnose the case. Probable diagnosis is a biologic. I like to highlight the word biologic diagnosis, means a biologic disease is type 2 diabetes mellitus. Now, in the part of the management, you have to say something. So may I request anyone to talk that to practice with me. That means you will talk to Mr. John and you are delivering information to Mr. John. How will you say? Please, anyone, feel free to join with us. Who will be the first? He can join first. Just to say, patient, your patient, Mr. John, that diagnosis so and so, and you are doing this now. Maybe, for example, it is a new diagnosis. Who will take the chance now? Always listener prefer. Dr. Habib, are you not free to talk? Dr. Habib, as other colleagues are not willing. Dr. Habib, do you have
Yes, sir.
time? Do you have time to talk now?
Yes, sir. Of course.
Fantastic, fantastic. Thank you very much. Let other colleague listen, but better to talk. It is a chance. So you understood the case right now, Dr. Habib?
Yes,
The
sir.
type 2 diabetes, Mr. John, 50 years, and it is a newly diagnosed case. So you are now to tell the management part of consultation. Okay. So,
Okay, sir.
so in this time, maybe Dr. Habib taking 2 minutes, for example, like in the examination, last 2 minutes. So don't take more than 2 minutes, Dr. Habib. Okay. And within 2 minutes, you have to finish. Really, in the exam, you will not get more than 2 minutes for the management part. So, other colleague, please try to follow us in our talk. Dr. Habib will be talking to Mr. John. And if you have anything, you can ask later on. You can write down in your paper any notes. You can share after our episode, rather to say. Dr. Habib, are you ready?
Okay, sir. So, Mr. Jones, whatever you told me, based on your history and examinations, I think you have a diagnosis of diabetes mellitus. So, here's I am giving you some management plan for your diabetes. There is some non-pharmacological and also some pharmacological management for your diabetes mellitus. In non-pharmacological methods, you should follow a routine workup. Just keep active for all day and do some physical exercise for weekly 30 minutes or 5 days in a week, and keep exercise and just maintain a well sleep hygiene also. And then in non-pharmacological and pharmacological method, you should do some oral. You have just follow some oral anti-hypoglycemic agent like some metformin or like this. And if your blood glucose level was not maintained with these oral medications, so we then go for insulin. Is it okay for you?
Okay, doctor.
Okay, so we should follow your blood sugar levels every day and with the glucometers in your home. Is it okay with you?
Okay, doctor.
Okay, so our next follow-up should be in after 1 weeks, and you should do some following investigations with our next follow-up. Is it okay with you?
Okay, doctor. Okay.
I will book you for next visit, and you will do these following investigations, like fasting blood sugar level and RBS, random blood sugar level.
Okay.
Uh, okay, so this is my contact numbers, and if you feel any further problems, please do not hesitate to contact with me. And another thing is that if you face any uh, uh, blurring of visions or any sweatings, please do some immediately actions, like if you falls your sugars, You also check it with your glucometers, and immediately you just eat some sugary items. Okay.
Okay, okay.
Okay.
So
Thank you.
doctor, do you like to start advise me to start medication today, right now?
Yes.
Okay, doctor. Okay, thank you very much. Thank you,
Okay,
Dr.
sir.
Habib. You already took more than 2 minutes.
Okay, sir. I am not prepared very
So,
well, and
no,
that's
no,
why I
I'm
am.
not telling that you are prepared well. We are not telling you that you are very well prepared. But as you started the talk, this is your advantage that you started the management. So we are here to discuss, no problem. If I start with the time management, the thing is that at the when you hear the word, the 2 minutes left, then there will be no alarming, right? Until
Yes.
the 10th minute. So it should be a reflex with us how to tell and how to minimize our the sentence length. Okay. So diabetes is a very big chapter, no doubt. And you diagnose the case diabetes. Diagnose means this is probable diagnosis, right?
Yes, sir. Yes.
Remember, the word is probable diagnosis. It is not confirmed diagnosis. Why probable diagnosis? As you understood, your patient have polyuria, polydipsia, weight gain. So in the management part, we will discuss a little later one by one, stepwise as much as possible. Dr. Habib, you already started treatment without being confirmed. Do you agree with me?
Yes, sir. Agree with you.
So is it good that not being confirmed and I am giving the medication, metformin and so and so? This is
Yes,
one
sir.
my
Absolutely.
observation. But I like
Mm.
to invite other colleague. What did you observe? Any mistake during talk? Please, anyone open the mic and discuss. Please, for short time. What did you observe us during talk from Dr. Habib? Yes, Dr. Atahar, please.
I'll I'll give you oral hypoglycemic, give you metformin, um, then pharmacological, non-pharmacological.
Now, please comment means if anything done wrong in your understanding, you can tell us. What
Um,
mistakes done by Dr. Habib?
these term are medical terms, so better to tell.
Oh, you
Mm,
like to say about the jargons, right?
yes, yes,
Very
yes.
right. So I have noted also as much as possible. Dr. Athar, can you say what jargons Dr. Habib used one by one?
Pharmacology,
Yes,
pharmacological,
very right.
non-pharmacological.
Give me chance to mark also. All of you, please listen. Pharmacologic, non-pharmacologic. Dr. Athar, how
Mm,
will you say in this time regarding pharmacologic, non-pharmacologic?
We we need to diagnose you, confirm your diagnosis first after some test, blood test.
Where,
Mm,
wait, Dr. Athar, sorry to stop you. This is the problem to comment and overcome the jargon. And
okay,
when we
okay,
discuss,
okay,
no,
okay, okay.
be connected, don't leave. Dr.
Mhm,
Habib, where Habib? Dr. Habib should be with us in discussion. We are commenting, Dr. Habib. You are telling that we have to diagnose the case. Then you are correcting pharmacologic, non-pharmacologic as a commentator, right?
mhm.
Problem is there, especially to
Okay.
overcome the jargon. We are explaining this is jargon, but we are using another jargon. For example,
We
no, 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 just listen, please. We're telling first we have to diagnose the disease. Actually, word diagnosis could be a jargon to the patient. So how to say? We have to say we need to be sure about your disease, right? I think it is very simpler, better word, comfortable word, not
mhm,
diagnose, diagnose. Understand
mhm.
how to say, Dr. Habib? Did you hear
Yes, sir. Sure. Sure.
what I
Yes.
said? How to say, Dr. Habib,
Yes, sir.
regarding
At
jargon?
first. Yes, sir.
That means we need to be sure about your disease, right? Not we will diagnose your disease. Understand how to say, Dr. Atar? Did you understand?
Mhm. Yes.
Can you try, Dr. Atar, this sentence?
Uh,
We need to be sure.
yes. We need to be sure about your disease first.
Yeah,
About
yes.
About your
Then
problem
problem,
first.
okay, fast, good. Then we will give
So, give you some medicinal and non-medicinal advice.
again semi-jargon.
Medicinal
Medicinal, non-medicinal. It is semi-jargon. Who can correct now?
about lifestyle
No, no, no,
and
no, 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 no. Medicinal. Better avoid the word medicinal. How to say now? Better to say medicine.
medicine.
Medicine. So it will be again a big chapter. Let me finish now about the jargon part here. Dr. Athar will be connected with us, including Dr. Habib and others as well. So Dr. Habib used the word in my listening. I have noted down. What is the diagnosis? Already I discussed. Dr. Habib said management plan. We have to say that I will give the treatment. Randomly, we are using our day-to-day practice. It is my management plan. Teacher is asking to the student, what is your management plan? This is talk between teacher and student, not with the patient. Remember it. So it is a reflex in our lips. You have to avoid it. We have to choose another simpler English word. So it should not be management plan. We have to say that I will treat you. Okay, in this way. So pharmacologic, Dr. Athar nicely knocked this issue. I will give you some medicine and I will advise you something other than medicine. Okay. Then one another way, it is called the paternalistic consultation, is that I am commanding the patient. Dr. Habib said, uh, you should follow these. I don't know, did you hear it or not? Dr. Sama possibly raised the hand first time. Dr. Sama, do you like to add here? You can open the mic also. Anything to add after my finishing? Should follow. Another one, oral anti. What was Dr. Habib? Oral anti-hypoglycemic drug. Maybe you uttered this, Dr. Habib. Oral
Yes, sir.
anti-hypoglycemic. Now you understand 100% jargon. Clear?
Yes, sir.
If you understand clear, so how to say?
Mm,
Again, I will give you medicine.
that will lower your blood glucose
Yes,
level,
yes, you can say that glucose lowering or sugar lowering,
sugar lowering. Yes.
sugar lowering medicine. So some word actually you should not rehearsal earlier. You can utilize your common sense, what we are using in day-to-day practice as a simple English word. Again, follow up, follow up. Okay, I will see you again. But we are
I will
using
see you
follow
again.
up all the time. Okay, follow up, follow up. We will come for the follow up. I will make a follow up plan like this. Though nowadays patient understand a little follow up, but some patient may not understand. You can imagine your surroundings, countrymen, people from the rural area, all of them don't understand word follow up. Some people only, few people only understand. So better to say very simple word. I will send you there. Okay. Then investigation. I will say I will do some test, not investigation. Investigation in the legal framework, it is police investigation, may be very alarming for the patient that you are investigating the patient. Clear now?
Yes.
The patient will be afraid. Yes, Dr. Sama, sorry, doctor, you lowered the hand to add anything.
Yes, Assalamu alaikum.
Dr. Sam,
Uh,
please, anything?
yes, I think it is better to check patient understanding and take his agreement on the management plan more often.
More often, yes. And I think Dr. Habib has done it. Dr. Sama Habib asked that, is it okay? Is it okay like that?
But at the end of the management plan, not from the beginning, an explanation of the diagnosis itself, like
Yes, that
diabetes.
is, you can
Yes,
say, explaining how it is actually, what is the disease, what does it mean? Okay,
yes.
right.
And
Then,
how about the dose and like the side effect and
okay, this is good.
yes,
But Dr. Sama, there is a trap. Trap means if you look at the screen, all of you, we use the word probable diagnosis. We still didn't confirm. Remember the word. And in the OSCE station also, initial thing will be like that, probable diagnosis. But very often, they can give you the blood sugar report, or examiner or surrogate will tell you when you advise for the confirmation of the disease, they will tell you fasting sugar is 13.5 and 2 hours after 75 gram glucose is 16 millimole per liter. Then you will be right? You will confirm the diagnosis. Then you can proceed with the dose and others. Be careful, okay? Don't
You
think
mean
that, no,
if
doctor,
it is
I like to say
okay?
you, it is called the be with the patient. What is our diagnosis today here shown to you? This is a probable diagnosis, right? It is not told as confirmed diagnosis. Even it is not told also simply diagnosis. If I say you in the screen diagnosis DM type 2, then you can say that this is a confirmed diagnosis. Their word utilized probable diagnosis. Probable means is a clinical. You suspected the diagnosis. Okay. And it is very easy to confirm.
Even
So
if I
you are
told
very right. You are very right. The station will be by the blood reports and others. And most of the time it will be a confirmed diagnosis of diabetes. There is no doubt. But is the writing like this today? It may be a little tricky here. So you need to confirm and advise to test just oral glucose tolerance test, and surrogate will tell you. If Dr. Habib would say that I will do this test, fasting blood sugar and other, then I will confirm the disease. Then I will say that, okay, sugar is like this, sugar is like that. Without giving me means surrogate today, time to respond, Dr. Habib has started the treatment. Okay.
um, I will not lose marks if I didn't, even if this. Yeah, I mean, I will tell like in this situation, I will tell after we confirm your
Yes.
problem, we
Yes.
will start this and that
Very
and that.
right, very right. It is a tricks, very right tricks. I will not lose the chance to tell about the management of the diagnosis. Very nice word, Dr. Sama, you have utilized. That is my suggestion also. I will not tell that this report is not available. I will, I will telling nothing. Not that. So
Mm.
this is the
Mhm.
skill we have to avail, and I think without practice we cannot achieve it. Only by reading books, texts, we cannot achieve. I think Dr. Habib and other, all of you understood what Dr. Sama said very nicely. I appreciate Dr. Sama. Though it is written as probable diagnosis, but I have to tell the management. Understood, Dr. Habib? This is just consultation skill or exam skill. How to say in the exam hall or the station. And in the management, again, I like to say you, already we discussed in the investigation skill in the previous class, but Dr. Habib couldn't utilize it. That is point of care test. What was that? Dr. Habib, did you attend our previous in the last week investigation?
No, sir.
No. Who attended? Anyone can help us and can memorize, remember what we discussed about the point of care test. For example, in such patient, what will be the point of care test? Please, anyone? Hope that some of you attended in the last week. Point of care. Yes, Dr.
It will
Ihsan.
be, yeah, it will be like fasting blood sugar
Yeah.
or the
No.
HbA1c.
Fasting. Sorry, doctor. I'm sorry. It was not point of care. HbA1c usually couldn't
Yeah,
be done in your chamber. Point of care means in your chamber as a family
yeah, it's
physician.
a random blood glucose test.
By capillary glucometer, doctor.
Yeah,
Capillary
capillary.
blood glucose. It is possible in your chamber, but not the lab
Yeah.
test. That we
Mm.
discussed in the last day exceptionally. Okay?
Yes.
Remember this thing. So Dr. Habib could do capillary blood glucose right now. Then we can fulfill a diagnostic criteria minimum by these, because patient symptomatic plus capillary blood glucose is, if it is a random fasting, we are not sure, but we can ask, are you in fasting now? Even it is not fasting also, it may be random, and random may be 15 millimole. So almost we are confirmed that patient have diabetes. Then we can start the treatment and others. This is one technical thing. Another thing, regarding a big disease like diabetes, actually within 2 minutes even I give you 5 minutes also, you cannot finish everything. Do you agree, Dr. Ihsan or other colleague? If it's a new diagnosis, I told
Yes.
you, new diagnosis, but you want to say the management, everything within 2 minutes, nobody can finish it. So you have to solve the problem in the management skill. That is the topic today. Skill we will be learning today, not the knowledge. Knowledge, you have full of knowledge. So how to do it, Dr. Sama?
Uh, I think it is better to do like signposting. Like I will tell the patient, Mr.
John.
John, yes, Mr. John, from your talking, from talking to you, I think you might have what we call diabetes. Do you know what is it? Like after explanation, I will say so. In order to treat this, we need to do some changes and to take some medicines. So and to follow up you with some lab test, with some blood test, so we can manage this. So we have some changes in lifestyle. We have some medication. We have some lab. We have some blood tests. We will do it now, and we will do it later to follow up you. We need to take care of your food and to follow and to see how about your kidney and your heart. Like this signposting, like
No, thank you, Dr.
what?
Sama. You tried your best, I understood.
Yes.
Whatever you tried, actually we cannot finish to tell by telling to the patient overall all whole management of diabetes. So in that case, we talk 1 minute or more than 1 minute for about 90 seconds, not more than that. And I tell you that I'm giving a literature or leaflet to you to know about the disease more. It may be a solution. Okay, doctor?
I have been told, doctor, I have been told it is they will not accept this leaflet because they are telling we don't have leaflet in our
No, no,
clinics.
doctor, we have the leaflet. Why not? I am doing my job, doctor, with my leaflet. Why will it will not be with you?
Mm-hmm.
You have to arrange it.
Okay.
It is a must. Education of the patient in the management part. If you start to educate the patient within 1 minute, 90 seconds, it is impossible. So say something little. Only
Mm-hmm.
start. Open the door only. Don't go
Actually,
inside. What I
actually,
like to say, Dr. Sama and others, in the management part, I will not start by saying that I am giving you a leaflet and you will learn. Not that. You start the talk, go up to 90 seconds around, then give a leaflet. Okay?
okay.
It is
Okay.
well accepted throughout the world. Nobody can deny it. Understand? This is our learning, and I am very confident to say. Okay? Any disease, you can never finish it. Only tell how to. Just I am summarizing of the slide, and we have to go the further also. There are many other slides for you. Any disease in explanation, we have to say how much you know about this disease. For example, Mr. John, how much you know about diabetes? Let the patient tell. Then he will start. So initial one, it is called E, means explore. Second, you will tell the remaining. After telling, second E, it is called explain. So 2E. The next E is listen back from the patient. What did you tell to the patient? So it is impractical again. Listen back from the patient. Time will not help you. So how to overcome it? Is it okay? Is it okay? That is the technique. Only it can save your time. Otherwise, if you want to listen from the patient, it will kill the time. Finally, after doing this episode, we can give the leaflet. The many other something there, I like to tell you later on. Even then, you can see in the leaflet, everything will be there. You just play some role there. Not that paper will be there. You will tell by yourself only. Anyway, that is the way to complete the informations. That is our suggestion. Fine. So already we discussed about the jargons and other things regarding diabetes. Diabetes is a very common disease. So we must know about these. And final thing is that, do you like to ask anything more? Do you like to add anything more? Finally, in the last few seconds. So I think we should not stay more here. We have to say something more also. And again, thanking to Dr. Habib to take the chance. But Dr. Habib and others also, if you like to comment here again, patient's perspective, what we are telling about regarding the management. Dr. Habib actually didn't touch many things there. Dr. Habib could say that I like to start with insulin and others, for example, but does patient perspective allow insulin or not? How much patient is educated, for example, in this case? And explaining in lay people language already we discussed. Lastly, risk of both of the treatment and no treatment. Time was not there. Can you remember, Dr. Habib? And all of you understood. Time was
Yes, sir.
not there to tell about risk of not taking the treatment, risk of taking the treatment. That means risk of taking treatment means side effect of the drug, for example, and no risk of no treatment means complication of the disease. It means I like to tell you at the bottom line, whatever you say, don't be more elaborative. And one tricks already I said you to provide the literature or something, even the website if educated patient, if you know about the educational status of the patient. Secondly, you have to touch this thing, risk of taking treatment and risk of not taking treatment. How to come to the point there. When you tell that I will give metformin and other, okay, then this so it will happen. There may be some, for example, hypoglycemia and other you advise, and patient will be aware, okay, better doctor, don't give me the tablet, I am afraid of these. The surrogate will actually lead you in this way. Then you can explain that the risk of the not taking the treatment, that means the bad outcome of the diabetes. This will be very lively discussion. But Dr. Habib, I think you need to practice very layman talk how to say. Knowledge is enough, knowledge is okay, but practice is important. Anyway, in later part, if any episode here with us, we'll invite you others. I hope none of you have further question. Already we discussed. And now coming to the next topic. The Royal College Examiners Board selected common mistakes done in the management skill by the candidate. Okay. Now, this is the list. Sporadically, we discuss these in many other sessions today, but we are only focusing today in the management part. For example, here, investigations related. In the previous skill related classes, I told you that was investigation, planning, and interpretation. But here a little touch because investigation is a part of the management. So in the investigations, they told the examiner understood, or examiner's comment is that our candidates do investigation inappropriately. Okay. So I will try to give you a little highlight from each of the point from top to bottom. So these are the total list in general, and come to one of them. First one, they commented very strongly, some candidates over investigate. So who can say me about over investigate means? What do you understand about over investigating? Can any colleague? For any disease, over investigate means, for example, our previous diabetic patient. How to say over investigate? It was our probable diagnosis first. Probable diagnosis, clinical diagnosis, not confirmed. So when it will be over investigation? Dr. Habib, have any idea about?
Sir, I think, sir, when we give hemoglobin A1C in these types of patients for early diagnosis of diabetes,
It may be over investigation, right? In one sense, though hemoglobin A1C will be one of the diagnostic parameter, but the best investigation will be fasting blood sugar and postprandial after 75 gram glucose.
yes, sir.
It will be very gold standard. So without doing this, I'm jumping to the hemoglobin A1C, maybe over investigation. Very right. There is very logic there. Without being confirmed about diabetes, we are advising other relevant investigations. So we have to say stepwise, right? If I say that fasting blood sugar 2 hours after 75 gram glucose, usually surrogate will show you the report, or surrogate will tell you by mouth. Then you can see the report, then you are confident. Then we have to say, I will do such and such, including ECG also, even urine analysis, creatinine, SGPT, and so on. then it will be justified. But initially, only by gazing, if I tell one by one in the one sentence, in one breath, this 8 and 12 investigation, some investigations might not be needed. This is one of the example. In any other diseases, try to be thinking, should I need the investigation in the first visit or not? I think that was their examiner's observation. Better to avoid over investigate. So how to avoid it, I will give you some tips for the holistic approach, though we discussed before in the last investigation class. Even then, I am repeating for your benefit. History taking, clinical examination, and investigation have actually three main objectives. Few common objectives. These are the things: diagnose the case, exclusion of the differential diagnosis, identify cause, comorbidity, complication, and so on. Okay, but when we will be busy for the complication, if I become confident about the diagnosis, then so in the initial visit, investigation plan should not include the investigation for the complication. Very, very right. Fine. So how to be guided? In the history, actually will guide for the examination plan. History and examination findings will guide for next investigation plan. And all three together actually guide us for the management. This is our understanding, a funnel approach. In this way, we have to proceed. Okay. Then the next point, the patient insufficiently involved in the management or decision. Insufficiently involved. Now, any colleague can give us some example when it will be insufficiently involvement by the patient in your management decision. Can anybody say? Dr. Sama, please.
We need to check with the patient. I will give, how about to start with you this metformin? It stops, will lower your blood sugar. You can take it every day with meals. Is it okay with you? And it can cause some tummy pain, but don't worry, we can manage it later. Can you do this?
Maybe one of the example. But again, if we come back to our diabetes patient, just Mr. John, we discussed 50 years, Mr. John, and is a very high blood sugar because he is having symptoms of diabetes, right? Symptomatic. Though there is symptomatic, we can advise the insulin treatment as well as we can advise the oral treatment, is that it? Insulin may be good as the symptoms are there. So we have to tell the patient there is treatment by the injections and treatment by the tablets. Okay? And benefit of injection so and so, tablet, benefit of the tablet is so and so. So yes, Mr. John, what do you think? What will be suitable for you? Understand?
Okay.
This is called involving the patient in the management plan. Okay? That is a very good example about today's patient, Mr. John. Again, in the UTI, patient having symptoms of UTI, but still we are not confirmed. In the UTI, though there is a guideline also telling that without blood culture, you can start antibiotic. But we may not start also because symptoms may not be really due to UTI. There are some symptoms for irritation in the urinary tract. We can give some, the solutions for minimizing the irritation in the urinary tract. For example, in the urethra or the bladder, there is some medicine. And after getting the blood, the urine report, urine culture or even the urine analysis report, then we can start antibiotics. So there are two possibilities in the first visit that we can start with antibiotic or without antibiotic, we can start some urine alkalinizer solution. So there are again two. So again, take decision is with the mutual understanding with the patient that what do you think better for you. So it can give an idea to involve the patient in the management decision. I hope all of you understood. Dr. Sama, what do you think?
Yes, yes.
In this way, in many situations, may not be only the management, even in the investigation also. The
Like
patient
an ambulatory blood pressure or
could be ambulatory
so-
blood pressure. Patient may not agree. Patient may tell that doctor, I don't have any house. I'm a backpacker moving here and there. I'm moving, I'm residing in the street. Isn't that it? There are some poor people. So how can he manage? Who will take care about this blood pressure machine in the street, for example? So we have to discuss with the patient which will be suitable, acceptable by the patient. This is called involve your patient sufficiently, not one-way command like that you need to do it. Dr. Habib said you should do it. Okay, Dr. Habib, should. How to avoid this word? We have to say it is better to do it. Dr. Habib,
Yes, sir, sure.
can you practice now? It is better to do it.
Yes, better to.
Yeah, better to do it. Not you should, you should. Right. Problem identification. Always we are busy with the diagnosis. And we started with the first slide, management of the patient, not management of the case or not management of the disease. So problem identification is must. Okay. You see what they are telling. Candidate is not expected in every case to make a clear diagnosis in 10-minute encounter. Clear, understand, Dr. Habib? Your diagnosis is not important all the time. But your management plan, approach, what you are thinking, this is important. One of the colleagues just yesterday, I don't know, he's here today, interestingly, he passed in this the July OSCE. And he's very happy and I appreciate him also. He informed me that, sir, my practice was not that much super, but I passed. Actually, what we have done for him, we actually taught him the skills, what already I have shown to you. Okay. And even frankly, he told me, sir, I actually in one station, my diagnosis was wrong. I was not sure. But he passed. What does it mean? Wherever your diagnosis is okay or not, it is not the main issue. Your issue is the scale, how you are telling, how you are explaining. Say some about the probable diagnosis, not confident or confirmed diagnosis. No worry. Okay. But rather, developing the differential diagnosis is best in somewhere. But in the diagnosis of diabetes, it is very clear to say by checking the blood sugar to be confident. But some other diagnosis, for example, in the connective tissue related diagnosis, disease, clinical diagnosis, the first thing, then confirmed by extraordinary tests are there. Sometime, for example, chronic fatigue syndrome, there is no specific test to diagnose it. But we can think of some differential for the fatigability, okay? The even added weight gain and other thing. There may be some psychiatric diagnosis to be added there, like depression. So these very fantastic to say about the differential diagnosis. That's enough for you, okay? But we have to consider this thing in the history examination and in the investigation, and problem identification will be based on minimum 3 parameters, biopsychosocial. These are 3 headlines. Those who attended this discussion before, all of you understood. For example, in the diabetes, the biologic diagnosis is the diabetes. Biologic diagnosis is the diabetes. But what about the psychologic? After listening the diabetes, how patient is reacting, okay? And father, mother, what about the patient's father, mother? Actually, patient is aware of having diabetes and patient suddenly become panicked also. In the future, there may be some trouble also. So how patient is reacting to us, from there we can identify some psychological issues also. Social issue, for example, patient doesn't have enough money, but we are advising to purchase very costly medicine. So it is a socio-economic issue. Already I told you about the social issue. Patient is alone, backpacker, moving here and there, no house, okay? And he's getting some social support by the government. So we cannot give the possible best treatment to the patient. So this is a social background, okay? For example, in this way, even patient is not educated. Patient cannot read the digits of insulin injection, for example, 6, 8, 10 unit, patient cannot understand, especially it happened in the South Asian countries. So the level of education also one of the social problem. So we have to identify this. So what we advise to you, and we advised before to our candidates, as there will be pen and paper. Pen means you should have a pen in your pocket when you enter the station, and there will be paper available on the table in the OSCE station. So you can write there like a prescription paper. Okay. Problems, number 1, 2, 3, 4, 5, even 6 problem will be there. For example, the diabetic patient is a smoker. So it is not under your diagnosis. It is a problem, health related problem. So you must include the smoking. If you skip it, your problem list will not be completed. Never and ever. So that is the examiner's comment. The problem list was poor. So hopefully you will be aware of this. And what is the book knowledge? If you see the book, the reference book, the we can have in this way. One headline is active problem and other problems are inactive problem. We cannot manage each and everything in the same day. So active means I like to manage today. This is one of the example for a patient of chest pain. You are thinking it is a myocardial infarction and patient have the left breast lump, female having axillary node. So it might be a suspected case of cancer and patient is a smoker. You got it now. So it is not the disease, it is a problem. So this is the active problem because further smoking will jeopardize the health of the patient. So you have to include in the active problem list. Next headline, inactive problem. Patient have a stable COPD. Patient perforated duodenal ulcer in 1977 or 10 years before. Patient does not have any dyspepsia or abdominal problem now. So it is inactive one. And patient might have osteoarthritis, but patient is not complaining knee pain today. So these are the inactive problems. This is the way of arranging the problems. So remember, not arranging the diagnosis. I like to repeat, list the problem and diagnosis will be one of the problem. Understood, Dr. Habib? As you open the
Yes, sir.
mic for that, I am asking. If any
Yes.
colleague open the mic, I will address you, no problem. And don't think that I am favoring Dr. Habib today. Anyone can share with us, right, Dr. Habib?
Yes,
Anyone
sir.
can
Sure.
share. And so what is the tips? Tips is record your conclusion, and the most likely diagnosis in order of probability. That is how to write the differential. In patient with multiple pathology, make a problem list so that the key issues are seen immediately, like today, active problems. For example, you understood in such patient, myocardial infarction should be treated fast. So we will take the decision for the management of myocardial infarction today, not about the smoking. Though we mentioned it, we can talk a little later also. We can tell that I will talk about your management, about something about the smoking later on. But I like to tell about something about your chest pain. In this way, we were to list one. Fine. So this is one example. And what actually we developed the checklist for you. And very recently we updated this thing. Those who attended our discussion 1 year before, it was not as such before. We rearranged and we made it very soothing and simpler for you. So this is the headline. According to the skill as much as possible, we have done it. Data gathering, focused exam, investigation plan, and the problem list for you. And we have to consider in the problem list red flag, idea, concern, expectation, impact in life, hidden agenda if there, and the ethical legal issues. It may be under problem list. So problem list doesn't mean only biopsychosocial. It is only about under the diagnosis headline, including complication and comorbidity. In the management part, what Dr. Habib tried his best to follow this thing, explaining of the disease, then for the referral or not, safety netting, that means identifying the red flags. And safety netting, I will tell you a little later. And pharmacologic, non-pharmacologic issues, ethical, legal issues, and opportunistic health promotion. So in the diabetes, smoking is not opportunistic. Smoking is a part of the cardiometabolic risk. But if a patient have gastroenteritis today, acute case, smoking will be an opportunistic health promotion. So especially smoking and the alcohol throughout the world, we must ask about. In South Asian people, another thing will be related in my practice, and even I talked before, excessive dietary salt intake in uncontrolled hypertension. It will be one of the risk also. So include it. Another inclusion will be betel leaf chewing, like this tobacco leaf, betel, very common practice in South Asian people. It should be included also as a part of the cardiovascular risk. Anyway, so these are the thing. It is not the time to discuss each and everything. Already you may, I believe most of you are aware of this checklist because many often we followed this. So in this list, what these, what I say, the abbreviations for the child, this is the point to explore. And the elderly, these are the points for ID. So this is a complete checklist for you. Anyone can raise the hand also if you want to ask further. Now the next point of examiner's observation, unsatisfactory pharmacological management. Okay. To make it satisfactory, candidate should be up to date about the medication. Okay. Nowadays, for example, of diabetes again, there are, what is that? The empagliflozin, Dr. Habib, sodium glucose transporter 2 inhibitor, right?
Yes, sir.
So it's not very decades before. It is only 4-5 years. It is available in the market, for example, 5 or 6 years, or at best 10 years throughout the world. But you are not aware of this because you passed your MBBS 20 years before, 15 years before. Definitely, we have some colleague like this, but you are not up to date about the medications newly developed. So you are not mentioning it, for example. Then your pharmacologic management will not be satisfactory. Okay. And international guidelines we need to consult or follow, especially the NICE guidelines. And in the drug management, important contraindication, we have to explore it. Okay. For example, patient having serum creatinine 2.5, but we are continuing metformin, it may be hazardous. So it is one of the contraindication of continuing metformin in a diabetic patient. So this contraindication, if you know, it is not enough. You have to share, or if you discuss with the patient also, you have to show that you know it. Okay, that is the thing. And this suggestion is that about the commonly encountered condition in the primary care, for example, diabetes, hypertension. Okay, so we must know about the asthma, COPD. We must know about the commonly encounter conditions, the appropriate medication according to the guideline. Okay, so these are the diseases: hypertension, diabetes, including tuberculosis, COPD, asthma. For the South Asian patients, tuberculosis is a must. So thing is that the concept is being evolved and evoluted. Suppose for 10 or 12 years before, during the preparation, some cases we are referring for each and every diseases. But nowadays, concept is that wherever the guidelines are available, we must treat the patient. We must start the treatment. As much as possible, investigate it. Explore the patient as much as possible by yourself. But something will be beyond your capability. For example, hypertension have some features of heart failure. As a GP, it is not your job to be trained with the ultrasonography. It is not mandatory for you in general. If you need an opinion from the ultrasonogram, sorry, I like to say the word rather echocardiogram. Okay, not ultrasonogram, echocardiogram, though it is one of the actually ultrasonogram. So you have to send to the cardiologist or appropriate center. So you are sending the patient for the echocardiogram. Okay. But you are the leader of the treatment for hypertension. Tuberculosis, you started the treatment. But whenever you are suspecting it is a multi-drug resistant tuberculosis, it will be beyond your grip as a family physician in the primary care. Then you can send patient to appropriate center. Even from the beginning also, you can send patient to the appropriate center for further evaluation. But don't tell that I am sending you, they will do their best. It is very, very unexpected in the exam. So especially whatever I have shown you here in the screen, you need to know about the latest guideline of the treatment. Then the next point is unsatisfactory non-pharmacologic management. Unsatisfactory non-pharmacologic. It should be practical and socio-culturally acceptable. Again, come back to obesity, diabetes, hypertension. You are telling that go for the exercise. Doctor, who can share or opine today? What is the common barrier of exercise in a patient of diabetes, hypertension you observe? You are telling that go 1 hour every day.
Yeah, obesity, lack of time,
Lack of time,
lack
one
of
of the
space,
barrier. Another,
lack of space,
space, one of the barrier. Another,
obesity.
obesity, doctor, already I am telling about. To reduce the body weight, you are telling do exercise.
Yeah,
So what are the problem that patient actually cannot? For the space, for the time, and any other? For example, patient have the space, patient have the time. Who can have experience of this? Every time you are facing this obesity, are you not advising your patient, doctor? Nobody talking.
Yeah, sometimes the
Obesity. Yeah,
patient
sometimes.
thinks like I need to go to the gym, this being my exercise, but actually it's not the way.
This is one of
And
the way. Another
regarding,
thing, what I like to say, for example, obesity produces the knee pain,
yeah,
joint pain. Obesity itself become a barrier for the obesity treatment by exercise. It is very common. 100 kilogram or 110 kilogram patient have the knee joint pain, but we are telling that go for the exercise 1 hour every day. Dr. Sama, do you like to add anything?
Uh, some patients feel ashamed,
Yes,
yes, or not believing in
could be.
the importance of yes
Could
of
be, could be. Even though now it is advanced, for example, in the Middle East countries, I think Sama can share with us that if you tell a lady to go out in the stadium, go in the street, easily they may not accept it to work. Isn't that it, doctor?
yes.
Though nowadays days are being changed in Middle East countries. And those who are living in Saudi Arabia, you know it that still I think the houses are closed. Windows are not open. Dr. Sama, you can share with us. Windows are not open like other
Yeah,
countries.
actually, in practice, we used to tell patient you can use stairs
Yes, maybe.
instead of
Again,
elevator. Yes,
again,
like
Dr.
this.
Sama, if you say stairs, patient have the knee joint pain.
Yeah, knee
Even she
joint. Yes,
cannot walk on
exactly.
the plain land. How can she go up with the stair?
Exactly. Yes,
That
yes,
is the
yes.
thing. That is the thing. I'm just giving an example. In case to case, it will vary. Be practical and advise which will be socio-culturally acceptable. Socio-culturally acceptable. So this is one of the advice for you, pharmacology, non-pharmacology. Poor safety netting. Poor safety netting means, for example, uh, you are giving aspirin or NSAID for any purpose. Most of the patient will develop stomach problem, right? GI upset, gastric problem. So we are not telling the patient whenever patient develop the side effect of the NSAID that stop the medicine, and then what patient will do. Maybe you are telling that, Mr. John, I'm giving this naproxen or other. You may have this thing. Okay. Okay. You are thinking that I have done well. But we are not telling after having the tummy pain, what patient will do. Dr. Sama, what patient will do?
Stop, stop this medication and come to me anytime.
Come to me.
Yes.
stop the
Stop and
medication
stop
and
this
seek
But
medication.
medical
but but
advice.
come to me. But patient can take some antacid syrup immediately. Come to me, okay, patient may come, but immediate relief, patient can take antacid syrup, even one PPI capsule also at home. Isn't that possible? Yes,
Mhm.
possible. So usually we advise PPI along with an NSAID, isn't it? Usually it is called the corrective drug. For the safety netting, we are giving the medication as well as we are advising something to be done by the patient self and where to get the help, the next help. Sometime next help is not needed at all, always not needed. Okay, after taking something, patient get rid of the problem. For example, one day patient took NSAID in empty stomach. Just imagine this thing. For this reason, patient have irritation and taking NSAID and the PPI, it is gone. Later on, patient getting the medication in the stomach after food, patient may not have the problem. So it doesn't mean that always patient will come to us also. Clear, Dr. Sama?
Yes.
So that thing should be clearly said to the patient. But again, I like to say time is important. Time is gold for you. If you are advising 5 medication, if you need to tell each and every medication, how many minutes you will take? Maybe 2-3 minutes. But we have to choose from there also what will be the common adverse effect happen by the medication. Minimum we have to say in this way. But how to overcome this? By telling an open type safety netting. What is open type safety netting? For example, you said about the NSAID and other, then the next sentence will be that, okay, if you, Mr. John, if you have any other way, any problem, anyhow, please come to us or knock me by over telephone or something. Then it can cover your consultation in this part. Okay? Understand, Dr. Sama?
Yes.
It is the technique. I'm trying my best
Yeah.
to let you know. You can do in another best way also. Okay. So they're telling about the safety netting you are not doing well. Okay. And red flags is there. Definitely safety netting will be there. And further investigation also part of the further management. No problem. The next comment was inappropriate referral. You are telling I will refer you to a nutritionist for the dietary advice and also to a cardiologist for your shortness of breath. So it will not be a proper referral. Actually, in this case, where will you send? Any doctor, any colleague? Patient have the obesity problem, patient have including the nutritional issue, and patient have cardiac problem due to shortness of breath. What will be your referral plan? Other than Dr. Sama,
First
any
to
other colleague?
cardiologist.
Dr.
Yeah,
Hassan is
first to cardiologist.
okay.
Yeah,
How
first to
to say?
cardiologist.
How to say? Dr.
Yeah.
Hassan, can you try to
Uh,
Mr. John? For example, Mr. John. Can you talk to Mr. John now? You are advising for the
uh,
referral. Please practice it.
Mr. John, your shortness of breath seems to be, heart is involved, and for this, I want to be seen by a cardiologist. So I'm making a plan for you to be seen by a cardiologist within a few weeks, or urgently, or right now. This should be the plan for according to the disease. And for the dietary advice, I can give you some leaflets. I can give you some. You can take help from the internet, and we can discuss this. We
Could be
can also
there.
involve the
Could be there, Dr. Hassan.
dietitian.
Thank you. I like to
Yeah,
stop you, Dr. Hassan. Don't mind because you are taking more
yeah,
time. Okay, Dr. Hassan, you are taking more
you,
time.
yeah, you're right.
Try to be shortened. Try to be shortened in your talk. Okay, simpler word,
Yeah.
less talk. Because we shouldn't kill our time. Because we will have many other issues. Problem list is big, 5 to 6. Okay. So very shortly, Mr. John, I will send to you heart specialist or heart clinic because I am thinking it may be serious if it is not treated. Later on, I will talk to about your dietary or the nutritional problem. Maybe finished. Is it, Dr. Hasan? Simpler.
Yes, yes, you're right.
Not to tell about that. Even you may not give, because if you give the dietary leaflet and other, what patient will do today? His body weight will not be lost within tomorrow. Isn't it? This is the reality. We can tell about the dietary issue later, but only show to examiner that you just address these and identified the problem. So according to the priority, we have to refer, and usually referral will be to a single place, not double today. Remember it. So examiner will see you that can you make priority list or not. Not only referral for this, all are rational or justified, but priority setting is important. So some of the candidate very happy. I sent to there. Rather, the candidate has done mistake. Referral should be one. Okay. And emergency should be identified. Okay. It should be according to the need of the patient. Okay. And then what is the basic principle of referral? We like to tell you something more and give you some exercise also after a few seconds. The principle is very simple. Apart from the incidents and emergency, and a few open access clinics, for example, genitourinary medicine, if patient need to be seen by hospital doctor, they have to be referred by a GP. That means you will refer. You will not feel shy for the referral. Which service is not available with you, you can even refer to the hospital also. Now, indication of the referral by principle for diagnostic purpose, for the treatment purpose, or sometime patient or relations request. It is a very tricky area. Patient requesting to be referred to somewhere. Always we will not accept it, but sometime we may consider according to the rationality. There are some other non-specific indication will be there. So these are the main areas where we will refer for the patient. Now, may I request Dr. Isan, please can you read it on behalf of me, this case?
Yeah, yeah.
please.
54-year-old woman present with postcoital bleeding. She underwent the menopause 4 years ago. You do a full pelvic examination, which is normal. Examination of the cervix is also normal. She has had symptoms for 6 weeks. She has a history of breast cancer and takes tamoxifen. What should we do? Number 8.
Thank you. No
Carry
need to
out.
read further.
Yeah.
Thank you very much. May I request all of you, if possible, make a problem list of the patient first, please. If anybody want to say, you can say directly, no problem. Problem list 1, 2, 3, according to the priority. You must do it today, doctor. Those who are listening today. Everyone, but anyone can tell. Open the mic. Anyone can start. Problem list. Already you took the history, you examine the patient, then you are making a problem list. Dr. Sama, please take the chance.
Postcoital bleeding,
Number 1. Second,
breast cancer,
examination cervix normal, had symptom, history of breast cancer. Second problem, then
mm, um, can we consider the menopause a problem here? Because
menopause may be a problem. If you want to manage the menopause today, minimum you could list in the inactive problem. If patient does not have the symptom today, does patient have symptom today?
not mentioned.
Not mentioned. So inactive problem.
Yes.
So
menopause
we will not
and breast
address
cancer.
today. We will not address today, but we must note in our prescription. But
Yes.
again, only mention the active problem. First is postcoital bleeding. Second problem is the patient is on the treatment of breast cancer.
Tamoxifen, yes.
Not breast cancer today problem. Is it?
Yes.
It is a history. So again, cancer always active. We cannot tell that cancer is stopped, right? By nature, it is a disease running, moving. In that case, it may be partially active and patient is on tamoxifen. Okay? Can tamoxifen may be a problem related issue?
Yes.
How?
It is related to cervical cancer in her case.
Tamoxifen may be related with the
endometrial.
cervical cancer. If I know this, if I am having this knowledge, then I can identify this is a problem. So I believe that unfortunately, many of us today don't know tamoxifen may be a cause of postcoital bleeding. Don't mind, my beloved colleagues. It is a little extraordinary message for you. If I don't understand, I cannot identify the problem. If I cannot identify the problem, your performance will not be good. That is the examiner mentioned, poor problem identification. Understand, Dr. Sama? And this question I picked up from AKT bundle, I'm sure. Those who attended our classes and sessions, you can remember. That I told before, the knowledge available in the AKT is enough for your performance in the OSCE. But you cannot perform if you cannot practice. Knowledge is not enough for you. So this is the knowledge. If it is true, keeping in the mind, in the problem list, then what will be your choice of management? From the 5 options, what will you do? Very tricky answers are there. Choose your best answer. Other colleague, new colleague, feel free to answer.
My option will be C, refer her urgently for specialist opinion.
Specialist opinion. Okay. And other colleague, Dr. Sama?
Same.
Same.
C.
Any different opinion by anyone? I think somebody should say, stop the tamoxifen. Already we know about the knowledge we shared. Tamoxifen may be cause of postcoital bleeding.
But there's 2 things: active breast cancer and the cancer with the cervical cancer is also already developed. So the first thing is
Dr. Hassan, if you discuss in this way, I like to ask you the urgently specialist opinion to whom? Cancer specialist or gynecologist?
Oncologist.
Oncologist. Which oncologist? Gynecological oncologist or breast oncologist? If I try to make it complicated. Gynecologist. Because your
Yeah, first,
priority number one is the postcoital bleeding. For this,
yeah.
Dr. Atar, do you like to add anything?
Stop tamoxifen.
Stop tamoxifen. Then you will stop also. Dr. Atar?
What
Hmm?
about breast cancer?
Dr.
If I
Athar,
stop
I
the
am asking, please be silent, Dr. Athar. I am asking you, Dr. Athar, you stop the tamoxifen and you think that for this patient it is sufficient, only stopping the tamoxifen?
No. And then refer to specialist opinion.
So your option is not there, then refer. Okay. In the OSCE station, you can actually join both opinion or 3 opinion from here. It will be the best. What we practiced before in the last investigation class, I remember within the last week. For the OSCE, you have to say, I will stop the tamoxifen right now, then I will refer or send the patient to a specialist. I think it will be the combined opinion best. But as option given there, best of 5 answer or single best. For this reason, I think Dr. Ihsan and Dr. Sama also commented about the 3. Am I right, Dr. Sama, Dr. Ihsan? Dr. Ihsan, where are you? So, Dr.
Yes,
Athar,
yes, see.
I think Dr. Athar is telling the best way. I will stop tamoxifen because I am suspecting that tamoxifen may be a cause. Stop means I will advise to not to take further tamoxifen, because if I stop tamoxifen, there will not be again big hazard immediately. We have to remember, Dr. Athar and everyone, we have to be cautious to tell not to take the medicine. For example, in a cardiac patient, it is if it is amiodarone for arrhythmia, and amiodarone causing the problem. Should I tell that stop amiodarone right now, then go to the cardiologist? What do you think? No, because amiodarone will be life-saving. But here, tamoxifen, if I stop tamoxifen today, it will not disturb the breast cancer immediately in a bigger amount. This is justification. Okay, this is the rationale. So we can say, I am advising not to take tamoxifen further, then I am arranging an urgent appointment with the oncologist or cancer specialist. It will be your communication. Anybody else to say anything more in this case? No more. Thank you. In the AKT format, this will be the best answer, no doubt. But for the OSCE, answer will be modified, because I am thinking tamoxifen could be a reason for the postcoital bleeding. You can add something else also if relevant. Okay, then tell that the first I am sending to you the gynecologist or the what I say, the female disease specialist center or clinic. Then if she refer or I will refer you or send you in the later on to your breast doctor again. You can add in this way also, the second line of referral. But priority should be there. Okay. Anyway, this is the message. Tamoxifen increases the risk of endometrial cancer. Though I am not sure. Remember, it is not the etiology. This is only predisposition. Because each and every tamoxifen patient will not have the endometrial cancer. This is only possibility. Huh? We have to explain it also. Thank you very much. Now, in the management part, sometimes you have to utilize the therapeutic trial. I'm just throwing an controversial issue to you. If anyone to discuss with us, you can start. Antihelminthic treatment without proper or confident diagnosis. Can we start? Sometimes we start. Is it? In South Asian perspective, those who are from Bangladesh or India, Nepal, anyone here? You can share. Do we go for confirmation of the presence of worm in the stool? Then I advise antihelminthic. Any colleague can share? I
No,
mentioned
no,
the country name also.
we
No,
don't.
usually we don't. Usually we, because antihelminthic is very cheaper and not having too much devastating side effect. Okay. Even without confirmation also, anti-tuberculosis treatment was given decades before, 10 years, 20 years before. But nowadays, are we starting anti-TB for the therapeutic trial? Very simply, possibly no. So in this sense also we can utilize therapeutic trial. In my sense, better not to be done by GP. But for simpler antihelminthic, okay, for the viral fever suspected, without investigation, we can give some symptomatic treatment, but not antiviral. Okay. Antihelminthic in general, we are not. But in some critical situations, in the differential diagnosis is there for the abdominal pain. At that situation, we need to go for the stool test to identify the worm. Maybe. But in general, we are not thinking. So most of the cases, therapeutic trial better to be done by the specialist. Okay, this is the suggestion for you. And now come to the later part. Candidates are unethical in the approach. Many often sporadically we discuss about the ethics. There are 4 headlines. So actually, I don't like to discuss this thing. I told you also before, if any time happen, we will give some example case wise. We will tell each and every point. But if anyone, any participant today like to ask anything about the 4 headlines, you can raise the hand and raise the question. Then I will reply. Anybody can help also. No one. So I believe that all of you understood, but I can give you now scenario here for myself, doctor, who want to read. Dr. Atahar, if you don't mind, a little longer, it can give some rest for me. Dr. Atahar, can you read it, the scenario? Only the patient scenario. Dr. Atahar, any trouble for you? Dr. Habib or any other colleague? Can anyone help?
Yes, sir. I will do it.
Please, Dr. Habib, proceed.
A 23 years old female attends clinic for a routine appointment regarding a 6-month history of occasional fits. She was seen the neurologist who have
Sorry, his interruption is there for some reason. Dr. Habib, can you repeat? Open the mic, Dr. Habib.
sir.
Please. Can you
Is it
repeat?
okay, sir?
Yeah, now
Okay, sir. Okay, sir. Okay. A 23 years old female attends clinic for a routine appointment regarding a 6-month history of occasional fits. She has seen the neurologist who have diagnosed idiopathic epilepsy and have prescribed lamotrigine. She informed you that she is doing well with this medication and has not had a fit for 2 months. She has been told that she must stop driving, but you have seen that she drove to attend the clinic. You discuss this with her and insist this. Sorry, sir. There is
insist that.
Insist driving, to which she
No.
informs
Insist that she stops driving, to which she
to which
informs
she
you that.
informed you that she had stopped driving, but since she is fit free, she must continue to drive because of her employment.
Thank you. The scenario clear to you, all of you. It's a matter of actually ethical and legal issue here. Okay. Summary is that you advise not to drive. Okay. She told that I stopped driving, but you observed that she drove her car or vehicle to see you in the clinic. So unfortunately, actually, she is hiding the information. Again, you advise that for the epilepsy to stop the driving, but she is not agreeing. Right, Dr. Habib?
Yes, sir.
Because for her job. This is an ethical issue. It's a common ethical issue about the driving. It may be a very important topic in the OSCE. Now the opinion. What will be your best opinion? Look at the 5 points. No need to read. Silently look at and give your opinion. From the 5, what will be the best opinion? Your advice is not being followed by the patient. Ideally, actually, patient is to inform the DVLA that this is my situation. My doctor told me, then what I have to do. But that means this driver will not inform the DBLA also. It is true. So what will be the best choice from 5 options?
Option A.
Dr. Asma telling option A.
Inform
Inform patient that you will notify the DVLA. Okay. Inform patient means doctor. Sorry, Dr. Asma, I have trouble with network. Just A. A means doctor will inform patient that I will notify the DVLA. I think it is the meaning. Is it, Dr. Asma? Yes, it is the meaning. Any other colleague to choose another answer, another option?
Yeah, I will go for the E.
E. What is the E? your only action is to write in these notes that the patient has been repeatedly warned but choose to ignore advice as she presents no serious risk in the view of her epilepsy control. So you agreed upon by the opinion of the patient. Is it, Dr.
No,
Habib?
no. This is like what the patient is thinking.
Yes. So try to understand the meaning.
Yeah,
So you are
yeah,
not agreeing with the patient, right?
yeah,
Patient understanding, is the patient understanding correct? No. So
yeah.
how
No,
can I agree with that?
yeah.
Anyway, any other colleague to choose any other option, B, C, D? I don't know what other colleague thinking. If you cannot think, you cannot decide in the exam. Definitely. Anyway, we don't have enough time to give you. So we got one A and E. So what will the best option? Answer is A. This is the legal responsibility. Okay. You need to inform the DVLA and you will inform the patient also, both together. This is the responsibility to tell the patient that, Mr. John, it is my responsibility to inform the DVLA regarding your driving issue. So I will inform you in time when I will inform the DVLA. This is the way of communication. So this is one of the legal responsibility by you. It is also part of your management. That is the thing. Okay. So you have to responsibility to take care of the other people in the society, isn't it? It is called the social benefit. If an epileptic patient is there, patient will kill other people. Driver will kill other people. So in this way, this is one of the legal responsibility. Next one. Who want to read? Otherwise, Dr. Habib, please help me. Dr. Habib.
Sir. Okay, sir. The aunt of a toddler requests that the child be given the MMR vaccination. She says that she is the child's parental aunt
Paternal
and
aunt.
paternal
Paternal
aunt,
aunt. That
paternal
means
aunt,
sister of the father, maybe. Is it?
father.
Yes.
Yes, sir. And that she knows her brother wants his daughter to receive the vaccine. What is the most appropriate action in this situation?
Do you understand the situation? She is telling that her brother means father of the toddler.
Yes, sir.
She is telling that my brother wants the daughter should have the vaccine, but father is not available here. So what actually will you decide?
Give the
Doctor,
child the MMR vaccine.
look at the
I have to,
options and choose your
yeah,
answer.
E.
E, Dr. Habib, E or A? Habib, A or
So
other?
just 1 minute, sir.
Okay, look at, no problem. Is a question again from the AKT. Doctor, no one to read
C
here?
option.
C. Dr. Asma telling C, decline to give vaccination request that child
Give
attend
the
for the MMR
vaccination.
vaccine with a person with paternal responsibility. Okay, but father is not there. Sister of the father is there.
Yeah.
So with her request, you will not
Yes.
give vaccination. Okay, Dr. Habib, your opinion or other colleague
Sir,
also?
sir, I think E.
E. Give the child the MMR vaccine because sister of father is telling, is it? But quoting the
Yes, sir.
father's issue, but father is not available. Okay. I think Dr. Habib is giving in your clinic, right? Whatever telling, I'm giving the vaccine because I have to give the vaccine to the baby. Okay. Other colleague telling nothing, only listening. Let's see. C is the best answer here. Why Dr. Asma having trouble with the internet? Otherwise, I could invite her to talk about more. Father is not there. Father is the legal, what is the legal guardian, not the aunt. Okay, Dr. Habib?
Yes,
So
sir.
with the request of the aunt, we cannot give the vaccine. Opinion should be given by the, it is called next of kin. Have you heard the word? Next of kin. It is a phrase. Next of kin, the legal guardian. Okay, with the nearest one. So you have to decline it. Okay. So this is one of the example of ethical issue rather to say here. Thank you very much to share. Now, few minutes maybe remaining with us, doctor. Try to be with us until the end. Some traditional asking, that is a finish about the examiner's comments about the mistakes in the management skill. I believe that all of you understood what we said until now. Now, what the question in the mind of the patient? I will show you because you need to be prepared for answer of the question. Patient have this question. What is the name of my disease? What is the cause of my disease? Is the disease curable completely? If not curable, how long will I survive? Okay. Can I get marriage if the patient is unmarried? Maybe male, maybe female. If then will there be any problem in my conjugal life after the marriage? Then if female, especially female surrogate will ask, will there be any problem of having baby? And if I conceive also, will there be a problem in my baby at all? This is very traditional question. You can add some more question also. It is very, very our personal collection thought process. You can add also. You can add me. You can tell me also. I will add here for future. Okay. These are the questions. So you need to be ready in the management part. And the last, because lastly, you will tell that, do you like to ask anything more? Do you like to add anything more? Patient may ask any one of the question from here for each and every disease. You need to be ready. And this actually summary of the management plan. Already we discussed somehow today. The explanation. Okay. Don't be judgmental. Reassurance. Linking the health belief to the therapeutic plan. Collaborative management. Already we discussed more. Join together, not one way from you. Exploring understanding by management plan by 3E model. I told you explain. Sorry, first is explore. Second is explain. Then again explore. So 3E model. Your decision will be maybe hospitalization or referral or OPD management by the follow-up with the safety netting. Whenever it is a home care, OPD management, safety netting must be there. Okay, safety netting must be there. Health promotion, it may be opportunistic. So these should be included in your management plan. I hope we tried our best to let you know. And in our checklist, we have written in this way, not as it is, but absorbing all the materials in this way. Explain, action plan will be like that. Okay. And above, we hide actually this message for our whole checklist. We are showing you only the management part according to the problem list. Still, if you have any query, you can raise your hand. And finally, in the consultation ending, first question will be, do you like to ask anything more? And what will be the next question, Dr. Habib? Do you like to ask anything more? And the next question?
Do you like to add something?
Yes. Do you like to add anything more?
Yeah.
Do you like to ask anything more? Do you like to add anything more? It means in your 10-minute consultation, you need to have that capability of the time management so that you can reach to these questions. Not suddenly in between, do you like to ask and do you like to add anything more and I'm finished? No. In a meaningful consultation should be over, then I like to ask this thing. Do you like to ask anything more? Do you like to add anything more? So today also, my question to you after the ending of the discussion, do you like to ask anything more? Do you like to add anything more of today's discussion? Please, doctor. Anyone? Until we discuss.
So my question is how we can manage this time. It's very difficult to manage.
Only practice, doctor. We are teaching you the tricks and tips, okay, with some example as best possible from our side. But we need to practice. Wherever I tell you, I am telling many often to you, but you are not practicing. Okay, you should have a friend or colleague to correct you. Singly impossible. Okay. And
Yes, sir.
usually we invite our colleagues to be with us in our group. If possibilities are there for you, you can join with us, anyone. We are
Yes,
not
sir.
actually doing everyday session, somebody requesting to arrange this thing, but we already made in the basic module. Already all of you know about, okay? Thank you very much. Thank you.
Thank you, sir.
Okay.